Thanks very much, Frank, Enrico, Dan, and Ken. My topic is potentially a controversial one. I'm only going to address one of the errors in carotid duplex, and I think, as I'll argue, how wrong can we be is very wrong. This is a report that many of us would see crossing our desk from our own lab or from an outside lab. It says internal carotid peak velocity is 185 centimeters per second. This symptomatic patient has a greater than 70% stenosis. Common report, commonly wrong. My disclosures are none, but I would say this is for mature audiences, and indeed some of you may find this data troubling. Bottom line of my talk is don't just measure systolic velocity, diastolic velocity, or IC-CC ratio. This is commonly done now and becoming increasingly common, avoiding the recommended guidelines. Rather, one should consider velocity and the image and the flow map and disturbed flow in making a final decision. That's my conclusion in summary. Let me go to some of the data. We're all familiar with ultrasound 101 as to how velocity is measured. It's based on the Doppler angle, that is the angle between the beam and the axis of flow, not the wall of the artery, the axis of flow, and of course the axis of flow is not necessarily parallel to the artery if there's any degree of tortuosity or any stenosis. Again, we're familiar with the Doppler equation, which shows that velocity depends on the cosine of the angle. That's part of the ugliness. We've known this since we started doing this many years ago. This table, which I'll enlarge the one part of, shows the errors that could occur in a peak velocity measurement based on a change in the angle. So at an angle of 60 degrees, if the optimum true velocity was 150, if you make an error of 5 degrees or 10 degrees, it could vary between 103 and 193 centimeters a second, not 150. Those are errors that are certainly within the real world. So what is the evidence that these errors can occur? I'm going to present 4 brief bits of evidence. First of all, this was a flow model study that we did with 3 ICAVO trained technologists, and we showed that if the mean measurement error was 0, that in fact in these patients, in these tubes, the variability of the measurements was plus or minus 15%. If we take that 15% as what is capable in a perfect situation, and we then extrapolate it to the data that we have, this is our graph, peak velocity on this axis, stenosis on this axis. In that case, with that error, we would see that the stenosis measurements, if indeed the mean was 200, would vary between 40 and roughly 60%. Of course, I'm sure your results are going to be better than these. This is our angiographic results from the old days on which we derived that curve. Again, velocity on this axis, stenosis on this axis. And of course, if you had a velocity of 200 centimeters a second, that would mean that you could have measurements in a patient somewhere between 50 and 75%. Of course, these are our results, which I'm sure you think were terrible and represent a shotgun on velocity, but Kirk Beach was kind enough to put together the largest 10 studies in the literature, and although you can't see the details here, you can see that there's a wide distribution. For peak systolic velocity on this axis, combining the 3,000 patients reported in the literature. This is the percent stenosis on this axis. So if, again, the velocity was 200 centimeters a second that you obtained from these published results, one would have a percent stenosis between roughly 50 and 80%. If you think diastolic is better, think again. If you think IC-CC ratio solves that problem, it does not. Hence, peak systolic does increase, as does diastolic and IC-CC ratio, with the severity of the stenosis. However, there is a very large overlap between the categories of stenosis, and it doesn't matter which categorization system you use, there is a large overlap. So how wrong can our reports be? If we just measure peak velocity, they can be very wrong. There are ways to improve that, and I showed that at the start. So in other words, if your report said that this patient had a 70% stenosis and that was based on one measurement of 185 centimeters per second in your lab or elsewhere, be cautious. The way to solve it is to not just measure peak velocity, diastolic, ICC ratio, but rather consider velocity and the image and the flow map all together in reaching a decision. Just like you do in clinical practice, you use all the information at hand. Not all labs do this. It's prone to error. Thank you.